So the topics which are covered are considering what is actually a normal joint, what actually is hip fracture, and how do people actually get it, and how do we actually prevent it? What are the causes of hip arthritis? What are the treatment options for them? And also what is actually hip replacement surgery? There's quite a lot of things to cover in a 1.5 hour period. So I hope to go through as much as I can. But after a certain time limit, I might actually stop and then start fielding questions if necessary. Okay, I don't have any conflicts of interest, nothing to declare. The general disclaimer which I give for all my talks is that this is only for generalized educational purposes. We actually do discuss about procedures and treatments, but the actual ones which are specific, which are more like useful for you itself, might be actually one which needs to be tailored accordingly to your own needs and problems. So I'm unable to actually provide one-to-one consultations or personal advice during this talk. In terms of copyrights, all the images and videos are actually used for educational, non-commercial purposes and as per fair use and fair dealing guidelines. So in terms of a normal hip joint, this is actually how I see it. In any joint in the body itself, it is roughly made of two bones. One is actually a top bone and a bottom bone. And in between, for it to actually move a joint, there's a need for actually there to be not only bone ends, but also more importantly, to actually be a protective cushion lining of cartilage. And that is essentially, for those who, that is essentially this lining itself is what actually keeps the two bone ends from touching each other. And that actually prevents the bone ends from grating, and it's the grating which causes pain. On top of this, there's actually a balloon cavity, which is what you see over here. And this balloon cavity actually helps to encase this particular joint. And the encasement is important because it allows for the joint fluid to actually wash around this area. And joint fluid essentially acts as a lubricant, allowing for increased, easier gliding of the joint surface itself without any chance of friction. So let's apply this to a normal hip joint. In this case, the top bone is the waist bone or the pelvis. That's what you can see over here, the pelvis. This is a cross-sectional view, and this is a 3D model. So you can see the pelvis is on top. And then below is actually the thigh bone, or what we call the femur. And the thigh bone is actually in this type of shape, while the pelvis is in this type of shape. So essentially, it's like a ball with a cup socket, and that's actually what hip joint is. So regardless of the shape or what bones there are, there's always going to be a need for cartilage. And in this case, you can see there's roughly about 2 millimeter to even 1.5 millimeter thickness of cartilage, which is just enough, which spans all the way through from birth till the elderly. And that's actually one which is of that rough thickness, and that's able to actually provide enough bearing surface to ensure that there's actually no contact of the two bone ends from touching each other. Then of course you can then see the joint lining and the coverings which are found over there. So these are some examples of x-rays for those who are actually interested. In this case, when we do x-rays, what we're essentially doing is casting a shadow of our bones using a light beam. In this case, where the light beam is one which is able to pass through the body and is stopped by things which are made of heavy elements, like example, calcium. So that's why we actually can see the bones, our various structures during an X-ray itself. In this case, it's actually what we call a composite structure. That means that you can actually see everything which is in 3D ends up as a 2D image. And this actually is what we see. And that's why it makes it a bit more challenging than what we see as actual photo or video of a 3D object itself when we see it, because it's actually compressed to a 2D object. In this case, you can see this is the pelvis or the waist bone. And this is actually the thigh bone. All right. So you can see the cup, the head being nicely fitted within the socket of the pelvis. And essentially, that's the most important thing. A round surface needing to be on another round surface, and they both being roughly in the same shape and size, so as to actually minimize, to allow for easy gliding and to reduce unnecessary friction. This is one which you see from the side view, and this is actually roughly all the x-rays which we normally do. What's the purpose of the hip joint? Well, the hip joint is actually one in which allows for force transmission. So force passing through the body, that means normally from the spine, gets split into two as we stand, and then it passes down the pelvis, the waist bone, going all the way down into the femur, the thigh bone. So it gets split into two. So that actually is a very important structure. It allows us to walk and allows us for load transmission. Movement itself is really down to the geometry of the bones. So by the nature of the fact that it's a round head together with of a ball of the thigh bone, the femur, together with the round cup of the waist bone, the pelvis, that allows for quite a lot of degrees of movement. And that is actually one in which we can then see why, in actual fact, we're able to do a lot of things. And it confers a lot of movement and freedom for a lot of people by the sheer fact that actually this particular joint can actually move so much. Yeah. More importantly, actually this ability for much movement in the hip joint actually allows for us to be able to do things which are also important other than just bending of the hip. Because bending of the hip is maybe what we think of as for here, but in reality, bending of the hip also is more for like this, like bending down to pick up things. Because the hip joint actually is one of the major contributors to the ability for one to actually bend down and pick up things. It's not, and actually only a small portion of it comes from the back. Most of the ability to actually bend down to pick up things is from the hip. Okay, and I think last but not least, in terms of discussion about what a normal hip joint is blood supply. I think the take-home message is that it's actually pretty complicated. But I think the take-home message in this case is that the blood supply in the hip in an adult is actually pretty tenuous, in a sense that all the blood supply comes from the major aorta, goes down, and then it actually runs its course all around as a ring in this part of the neck of the thigh bone. And then it shoots off individual, one by one, individual small little arteries, which then goes into the head. And it's all these small little arteries, these small little capillaries or arteries, which actually then deliver all that blood supply to the dome, to the actual ball of the thigh bone. And so you can imagine if, let's say, like we make a cut over here, everything is fine. There's still enough blood supply. Why? Because there's actually a ring of blood supply over here. But if we start to actually damage or compromise structures, especially over here, now once actually one of these structures is compromised, that particular patch of bone is actually deprived of blood supply, and that leads on to actually bone death. And bone death is one which actually is something which is important to discuss about, because that's actually one of the most common causes of arthritis in the hip. Okay, let's talk about hip fractures. Hip fractures is actually getting more and more common as we are actually having more and more of our population as we get older, essentially. And it's actually for a number of reasons. Number one is due to what we call this concept of frailty, where a combination of, as we get older, our muscles we get a bit more and more tighter, less range of motion in our joints, more contracted tendons, together with progressively loss of muscle strength. That actually tends to actually increase the risk of falls. Other than that, there's also many other reasons why actually there could be frequent falls too, and that actually tends to actually accrue and to become more and more common as we actually advance in age. Apart from this, also there's actually aging-related changes in the bone. And wow, just like white hair, as we get older, we start developing more and more white hair. The same applies for bone. As we get older, there's actually some changes in the bone where there's actually increasing levels of loss of calcium and also phosphate within the bone, leading on to actually eventual loss of it, increasing weakness of the bone itself. So this term is called osteoporosis. Now, a normal bone is what you see on the left, while increasingly osteoporotic bone is what you see on the right. Generally speaking, the rough architecture of the bone doesn't really change. Outside, it looks all the same. There's no difference at all. But it's the inside which counts, because all of these things, this honeycomb pattern of bone itself, what it does is that it allows for the bone to be not so heavy, but yet at the same time strong. But as we get older and older, all that honeycomb pattern starts to actually become more and more tenuous. All the connections, the bridging of bone itself start to actually become less and less becomes thinner, and also starts to actually break down to the effect that it becomes a bit more porous. And that's where how osteoporosis becomes a term, because osteo is actually bone, while porosis is actually talking about this concept of there actually being increasing levels of porosity, of levels of larger bubbles of sponginess in the bone itself. So how does this occur? It occurs with time. Okay, we tend to actually gain the most amount of bone mass, bone mineral density, as we actually grow from our infant to actually early adulthood. And the tide changes between 25 to 35 years of age, where actually aging starts to creep up. And ultimately enough, some hormonal changes like menopause tends to actually occur at certain predefined time periods. And that's when actually most of that bone mineral density starts to actually decline quite significantly, until to a time where there's actually a increased risk where just a normal simple fall with low energy can actually cause the bone to break. And that actually is a certain threshold sometime down the line itself, around the region of 65 to 85 years of age. There's a time also when falls tend to occur more and more frequently, and these causes of falls itself is for many, many causes, but more often than not, at least in the normal healthy individual, is due to actually muscle loss, what we call sarcopenia. Okay, there's actually a difference in terms of bone mass between the males and females. So you can see that males tend to actually have a much higher bone mass than females for any given age. And more importantly, is at about 55 onwards itself, when menopause starts to happen. That's when actually the bone mineral density decreases more significantly in females than males. This one is actually noted to be consistent throughout all populations, whether it's actually Caucasians, Chinese, or Indians, or Malays. And ultimately enough, it's actually just effect of the normal physiology of the body itself. Of course, right, males tend to also have other problems. We have higher risks of ischemic heart disease, that is heart attacks, than females. And it's really, really down to the play of all these aging-related effects. So everybody actually has bone mineral. If I were to actually ask everybody in the audience to actually have their bone mineral density checked, well, it will all end up, everybody will roughly end up as 1 point along this curve. And out of that, about 5% of the population would actually be a bit more osteoporotic, okay, than the rest. And is in between a normal person and a person who's osteoporotic. That one is actually what we call as osteopenia. That means it is enough to actually be worrying and requiring a bit of treatment, but at the same time, not significantly enough that the risk of fractures are that high, that we need to actually take extra precaution and start giving real medications to treat it. So You can see that as we get older and older and older, that means here's the age 25, 35, 45, 55. This the group of this green segment itself becomes more and more significant, and this actually is one in which helps to symbolize how as we get older itself, the osteoporosis rates start to increase more and more dramatically. Okay, but regardless of all these age-related things, it's actually the fall which actually causes the hip fracture. And a fall can be just as simple as just a simple slip, a trip, or maybe even sitting down onto a chair and not being actually mindful of where exactly the chair is, such that an individual actually just flops off of the chair, a chair's height, roughly about 50 cm. And that's enough to actually cause a crack in the bone, especially in those who are osteoporotic, especially in those who are advancing in age. So all these hip fractures can be of multiple different geometries and patterns and locations itself. But no matter what, all these, everyone ends up with the same sort of effects, which is pain definitely, and pain enough such that which is quite severe. And there's actually an inability to walk or move at all. And it's only better when they're actually lying still, and any small movement causes pain. Why? Because of the fracture ends, the sharp ends actually grating against each other and causing all the inflammation and pain. Because of this inability to actually move, most patients are only able to lie down on the floor and they couldn't actually get up at all. The problem then is that if, let's say, the person is actually at home by themselves all alone, there's a risk of actually not being able to seek help because the injured individual is unable to actually get up on the floor through a telephone and is unable to actually mobilize due to the pain. So there's that risk that actually there could be a prolonged period where the person could actually be on the floor for a long period of time, and that can cause problems. Okay, so everybody tends to ask me the same questions, and that is, what happens to those who actually choose to not do any surgery? Well, in terms of without surgery itself, in this case, okay, let's backtrack. I need to rewind a bit. So in this case, normally most times the patient gets actually sent to the A&E. Then we will see them actually in the orthopedic department in the hospital. And then that's when we actually will counsel. And more often than not, if a person is actually healthy without any major medical problems, we will actually counsel for surgery. Where surgery is actually one to allow for us to actually relieve a few things, which is to relieve pain, to allow for easier nursing, and to actually allow for mobility, to actually go back to being able to walk again. So without surgery, what are the immediate issues? Number one, of course, is pain. This one can be actually treated by a few methods. One of them is actually pulling the leg literally with a traction device. That is actually literally just putting a sticky tape onto the skin or tape on the skin, and then actually pulling it by a combination of cord, rope, and weights. Medication helps, and also sometimes we might actually get our anesthetic colleagues to actually inject some special nerve blocking agents into the surrounding nerves so as to actually numb the area away. Nursing still is actually difficult without any form of surgery, because every time we want to actually move the individual, it actually just causes the bone ends to rub against each other and cause pain. So you can imagine how painful it can be. And the problem is that we need to actually do frequent rotations, because without frequent rotations in the bed, any prolonged pressure on skin, especially let's say like the backside or in the back itself, can actually cause the skin to slowly break down and lead on to bed sores. And these bed sores can be painful by itself, no doubt, but more importantly, it can also get infected, and that can also cause problems to life. Infections in the lung and urine are also more and more common, especially in patients who actually lie down for prolonged period of time due to hip fractures. And more often, the infections are actually the lung and the urine infections. Blood clots in the veins can also occur, and that's because of sheer immobility being lying down in bed for a long period of time. Now, these blood clots in the veins doesn't cause any much problems unless they actually start to become longer and longer and bigger and start to shoot up in the bloodstream. And where do they lodge in? They lodge into the next pass. They pass through the heart and they get lodged into the lungs. And if they get lodged into the lungs, that can cause potentially life-threatening, limb-threatening. I don't not say limb-threatening, but life-threatening breathlessness. Because right, the whole idea of blood going to the lungs is to actually oxygenate the lungs, oxygenate the blood itself. And here we have a blood clot which actually shoots up from the veins and gets lodged in the lungs and stops that part of the lungs from actually doing its duty of oxygen and carbon dioxide exchange. Prolonged periods of immobility also tend to cause quite significant wasting of muscle. And this actually can be pretty significant over time. And this can be up to even a 10% loss of strength of muscle over a period of 1 week. So you can imagine just by the fact that a person actually sits or more like stays in bed for 1 month, it will cause up to 40% loss to 50% loss of muscle strength. And you do need actually all that strength in order to actually get it back on the feet itself and to do things. So that's another thing altogether. Prolonged lack of movement of the joints tend to also cause the joints to stiffen up and cause contractures. So these are all immediate issues within the first week or two. How about, let's say, like long-term issues without surgery, without doing anything for these individuals? Well, one problem is that then, number one, with certainty or almost close to about 95% to about even 98% of the time, the bone ends just don't heal. And the reason why it just doesn't heal is because there's just way too much movement, and the edges and of the bone itself just aren't in contact with each other. So any form of incomplete bone healing will just lead on to continued pain in that region. And more often than not, there is actually no bone healing occurring at all. There will be persistent pain, which can last for quite a while. Most times, at least for 3 to 4 weeks, there's actually significant enough pain to the effect that the patient is actually going to be lying down in bed for that period of time. But as the pain starts to dwindle down, we will try to aggressively transfer them to the chair, to the wheelchair itself. And transferring to wheelchair is important because it helps to prevent all those complications as what was discussed previously. So roughly speaking, in about 1 or 2 months, a person is able to actually comfortably stay in the wheelchair. Roughly about 6 months, they will actually be relatively pain-free. There's no harm to try actually walking, but at the time, but most people will actually still be in a bit of pain. And the likelihood of being able to actually walk ever again is pretty low, less than 5% without surgery. So this can actually cause loss of independence, where the person is actually wheelchair bound for life, and that can lead on to depression and loss of quality of life. So the aims of surgery in this case is actually trying to allow for the reversal of all these things you described. So it's to relieve pain and suffering, to allow for easier care and nursing, and to actually prevent all those complications from prolonged immobility, as what was discussed previously. And the hope is that the person is able to actually go back to previous levels of mobility. We can't bring them back to something better than before the fracture itself, but at least we can bring it back to some semblance of ability of mobility, and to allow for the individual to gain independence again. So how do we go about it? It's actually a very, very methodical, systematic way of doing it, at least for most government hospitals. And what we essentially do is the individual is going to be actually cared for by more than one doctor, and it's going to be a multidisciplinary care type setup, where there's not only going to be a surgeon who helps to actually offer surgery, but also another doctor who actually cares for the elderly. And they actually do a good job of being able to holistically take care of the elderly individual, because there's normally more than one problem which actually comes to be. So sometimes it can be a lung infection which causes the fall, or urine infection which causes dizziness, which then leads on to a fall itself. So there's actually not only just fracture, but also other problems too. They actually help in this regards. And what they actually help, especially most for, is to actually ensure that these individuals, these patients are actually optimized as much as possible before surgery itself, so that as to actually reduce the risk of surgery, and to actually also help to stratify the risk, to know what's the odds lah, in terms of what the percentage odds are in terms of risk of a particular event happening during surgery itself. And normally this is what we will actually need to know, so that at least when we actually have a family conference, we can have an informed decision making, and we can discuss in a very, very meaningful way what are the benefits of surgery and what are the risks, together with statistical risk of surgery itself. So surgery is normally done when safe, but normally if we can, we prefer to actually do it as early as possible within a 48-hour period. And the reason why is because we have actually done many, many studies, both locally and overseas too, where we could see that any surgery done before 48 hours tends to actually have quite a good outcome. Or those who are past 48 hours, there's actually a slightly increased risk of complications, both in terms of infection risk, but also in terms of mortality risk itself. Pain control is definitely one which we will give, and we tend to be pretty aggressive in trying to actually get patients on their feet as soon as possible. So normally after surgery itself, the next day, we will actually advocate immediate early mobilization. That means come into hospital, first day come into hospital, second day get surgery done, third day stand out and walk. It's roughly that type of idea. Of course, right, the rehabilitation, right, would not be actually so immediate. Standing out and walk is with a walking frame with two helpers behind is very different from one in which a person is able to stand up and walk meaningfully without any aid or helpers. So that requires more extensive rehabilitation. And that's when we actually normally would discharge the patient to a community hospital, a step-down care facility, where we will actually give time for all that recuperation to occur. And more importantly, more often than not, give time for family members to actually get extra helping hand, or get everything sorted out at home itself in preparation for the transition back home. So long-term itself is that chronic disease management again. We're talking about osteoporosis and falls management. This one is normally follow-up done by our care of the elderly doctors, our geriatricians. Okay, so this is what normally a normal typical pattern for a patient who goes for surgery would have to go through. Number one is they will actually have to receive either spinal anesthesia or general anesthesia. More often than not, the majority of the time is spinal anesthesia, and that is actually just injecting some numbing medication to the nerves itself at the back, and that numbs the entire red part of the body. That means the bottom part of the body totally for surgery to occur, which normally lasts for about 1 hour to 1.5 hours. The spinal normally lasts for about 2 to 3 hours, sometimes even up to 12 hours at times. During this, after the spinaling, we will actually place most patients into this particular contraption, which helps to pull the leg back into position. And by pulling the leg back into position, it allows for the fracture to go back to its original geometry. Essentially, it's what we are essentially just putting all the jigsaw pieces back together. I think it's the best way of saying it. And or maybe let's say like putting back the broken teapot together, that type of idea itself. And then after that, once it's back into its correct shape, that's why we actually put in fire through certain specific metal implants to hold that shape in place. So there's one way of doing it, putting screws. There's another way of doing it, putting a long rod together with another screw inside the area itself. Exactly what is being used is dependent on the actual pattern of the fracture. As you can see here, in this case, this one is actually quite high up, or here it's a bit lower down, and that dictates the type of patterns itself of fixation. And this is also another one where we actually put not only the little screw, the big screw in the middle, but also a plate and little screws on the side. So it comes in many ways and different guises. So let's just say, for example, this particular fracture is one which is occurring quite low down. In this case, you can actually do this, where we actually put it back into place, and over time, right, this area will heal. So this is actually a temporary fixation device, where after pulling the fracture back into its actual position, we will then actually put the plate and screws, and that holds everything in place enough that a person is able to stand and walk and do most things. Now, we still need to depend on the fracture to heal, because ultimately enough, after about 1 or 2 years, no matter what, if the fracture doesn't heal, the metal plates or screws will all break anyway, because all these things tend to break with time. Just think of it like a paper clip. If you actually were to bend a paper clip too many times, it will break. So same idea here. So the key and most important thing is bone healing. And in this case, you can see the bone is slowly healing over time. In fact, if you look carefully, this particular fracture has by itself, right, started to actually move a bit, which is by design. And the movement actually causes the two bone ends, which is this part and this part, to gnash into each other, to compress into each other. And the compression ensures that it heals. So same idea here for a different type of fracture. Sometimes we actually would put, instead of those plate and screws, into long rods together with into the body itself. This is becoming more and more frequent. Why? Because we are actually realizing that they are actually more reliable with lower chances of complications after surgery. This one sometimes we will do where we put individual screws into the area. Normally we will do it for not so severe fractures, and normally for those who are younger in age. But however, sometimes right, these can also have, end up with problems. Why? Because ultimately there's certain types of fractures which tend to actually cause the head to die off. And you remember when we were talking about it previously, talking about blood supply? Yeah. Sometimes the fracture can occur here or here. And because of that, it then tends to cause all these individual arteries, little blood vessels to actually break off. And this breaking off of the blood vessels which then cause the lack of blood supply to the head. The head will die off with time. So when the head dies off with time, immediately within the first 1 year, it's not a problem. Within the first few months, it's not a problem. But over time with use, what happens is that this area tends to actually soften out. And when it softens out, essentially what happens is it becomes a sinkhole. So the tarmac, which is the cartilage, is actually intact, but the underlying soil, the bone itself, becomes soft and it disappears underneath until eventually the hole is so big that it causes the tarmac to sink in. So if you check all those YouTube videos where you see that large lorry suddenly fall into a big hole where there was none previously, this is the idea itself, where dead bone causes softening of the bone. The death of the bone itself leads on to eventual softening at the most important place, which is where it's actually receiving all the stress. And eventually, when that area collapses, the cartilage collapses down with it, and that leads on to a roughening of the head. And you can imagine a roughening head tends to lead to actually a lot of scratching and grating within the joint, and that leads on to severe arthritis. So in this case, there is actually a rationale for us to actually consider a different approach. So this is actually a normal head, which actually had a fracture, and we put screws inside. But over time, due to the loss of blood supply to the head, the area collapses. That's what you can see here. The actual term for this is called avascular necrosis. Avascular means the lack of blood supply, and necrosis is actually just a Latin name for death of bone. So if this, since we know that this actually sometimes can occur, we will then choose to actually adopt a totally different strategy where we do not want to actually retain that piece anymore. Let me go back. We do not want to retain. We don't want to retain the head anymore. Instead, since we know that there's actually a high chance of it dying off and leading on to arthritis, instead what we do is that we just take it off. And when we take it off, we have to replace it with something. And this is what you see over here then. Okay, where we actually take off the head, knowing that in about 30-40% of individuals, it will die off, and replacing it with an artificial one which is actually made of metal and plastic. And in this case, it cannot exist by itself, and it has to be connected to the rest of the thigh bone. So then we have to place and implant it in this long stem, which is held on by either a combination of a good fit, or if not, using cement, which is made of normally plastic acrylic cement. So regardless of all these surgeries, the important thing to think of is that all these fractures tend to be sentinel events. So we do know that there's actually a risk of mortality at the 1 year mark of roughly up to 22% in all patients with hip fractures. And it might be just the start of many things. And normally a hip fracture tends to actually be a reason for a fall, which causes a hip fracture. It's normally due to many reasons. And it's likely one of these reasons which then cause mortality at the 1 year mark, the 22% rate. Regardless, even without thinking in terms of eventual mortality at the 1 year mark, we then start to think about in terms of ability to return to function again. And what we know is that roughly 1/3 of patients who have hip fracture surgery, that means those with surgery, not to say those without surgery, are able to go back to 100% full function. That is 33% of the time. Another 1/3 still would actually have some level of physical impediment, needing walking aids to make sure that they don't fall down anymore in the future. And even then, still there's always that 33% left who still are actually semi-dependent, needing somebody else to help them, or who need actually quite intensive help, to the effect that sometimes it might be actually one in which there needs to be actually placement, where it's like day rehab or the community, or let's say like nursing home, or a need for more advanced care, long-term care. So it is maybe more related to the demographics, because clearly, right, as we are older, and when we actually have these type of fractures in the surgery itself, there's going to be some level of functional decline even after that. So this is roughly what we know. Okay, it's roughly 30%, about 30% and 30% again. Okay, where the 10% is actually those who decide not for surgery, or those who cannot go for surgery because of other reasons as well. Okay, I think prevention is always the best treatment. I'm not going to go through in that great detail about this, but these are some examples which I can see over here. In fact, actually there's a totally different entire set of lectures which I give for prevention of hip fractures and prevention of falls. But this is an example as a taster. So let's say, for example, going to the toilet at night. That's quite a common issue, and that's actually the most common, one of the very common causes of falls and hip fractures, especially at night. So the first and most obviously is emptying the bladder before sleep, avoiding medications which can cause drowsiness, if possible. Good night lights, which are bright and automatic if possible, because clearly, right, if you leave the light on in the room, you can't really sleep, and that affects quality of life, and also that affects the ability to actually sleep, and you tend to actually then be more sleepy in the daytime, which then leads on to actually falls in the daytime itself instead of night. More importantly, is actually no obstructions on the floor. Example, wires and carpets. These are things to be careful of. Even right, shoe wear can also be obstructions on the floor. So it's important to make sure that your shoe wear is always placed in a particular place and not anywhere in itself. Even let's say like the floor, if it's actually of smooth tiles, might be a good idea to actually start lining it with some non-slip friction tape, which is quite easy to be purchased online, or in any good hardware shop downtown. And look carefully, especially when trying to sit down, because sometimes it might not be exactly where it is, and that leads on to falls in itself. The installation of handlebars in the toilet is always a good idea, especially right after the first fall or subsequent falls, because that increases stability and allows for a controlled, easier time to actually get up from the seat or get down from the seat itself. But there are more than that itself, and that's for another day. Okay, I think that's it for hip fractures, and now we can move on to hip arthritis. I know it's quite a lot of information. I'll just continue going on and on and on, and I will try to address all questions as much as I can over time. So, oops, excuse me a moment. Okay. Okay, so what is hip arthritis? Essentially, is just the wear and tear, or this essentially is just the linings in it's causing the lining of the hip joint, the ball and socket, all that cartilage being slowly worn out, to the effect that it's now the bone and the bone grinding against each other. And this grinding of bone causes inflammation, pain, and also deformity. So some of you who actually have seen my knee lectures would be familiar with these few slides, and it's just giving the various causes of hip arthritis. So one of them can be due to trauma, infection, or injury, where the fact that there's actually some defect in the joint itself. This is actually the knee. Apologies again, but some defect in the area itself causes the development of rough, uneven surfaces. So you can imagine it's a bit like the development of a cheese grater within the hip joint itself, and that will slowly just wear out things. Gout and calcium can sometimes cause the development of crystals to form. It's not to say that everybody gets calcium to form in their hip joint. Only specific individuals are predisposed to this. Okay? Yeah. And we're talking about gout and pseudo gout here. And these crystals tend to be sharp, and they tend to deposit in certain areas of the joint lining, which then gets irritated, and the lining of the joint, when irritated, tends to start to eat into the cartilage itself, and that causes the arthritis. Sometimes it's the body attacking itself. Autoimmune diseases, let's say like rheumatoid arthritis, generate a lot of antibodies, or more like antibodies against the body, and these antibodies with antigens, when they actually bind together, they tend to actually accumulate normally in the joints, especially the big joints, and that causes a lot of joint lining inflammation. And when the joint lining is attacked, it gets inflamed, it leads on to all this eating away of the cartilage too. But more often than not, most times, arthritis in the hip is due to overuse and aging. With certain people more predisposed to this than others, it's to do with a bit of predilection from genetics. And it's also to do with maybe in the past, when much younger, that means when maybe even, let's say 1 to 6 months old, there being a chance of the hip actually being not very stable, leading on to the bones developing slightly differently than others. When the bones are being developed slightly differently than others, they are more prone to overuse and to aging, leading on to faster mechanical wear and tear. Okay, so these are the typical causes of this, of any form of arthritis in any part of the body. Specific to the hip, we're still talking about this idea of lack of blood supply, which causes bone death itself. So this one I've already alluded to during the hip fracture talk. And in this case, what is happening here is still, as how I would like to actually explain to you, is essentially like a sinkhole, where it is actually a nice flat surface of tarmac, but underneath it, the ground has actually dropped off. And because of that, whenever there's any load, big heavy lorry goes across it, suddenly the lorry just caves, the tarmac just gives way, and the lorry just sinks into the sinkhole itself, or more like falls into the sinkhole itself. So why is it that actually this happens? It's due to actually the bone death leading on the softening of the bone in this area, which takes time. There's more than one cause for this. Okay, and more in that is when actually this collapses, the geometry is lost. It's no longer circular. It's no longer a nice golf ball, hemispherical ball. So because of this roughness, it essentially is introducing a cheese grater into the hip joint. And you can imagine that's what's going to cause all that pain. So dislocations and fractures can cause this. This one we knew already. But also, interestingly enough, there are also other causes too. One example is like alcohol and excessive alcohol intake, especially binge drinking of alcohol. This is very, very common, especially in Taiwan, Korea, Japan, and China, especially in young males, because of this, and that leads on to this actually form of bone death. It's less of taking a simple glass of wine. It's more like taking like a whole bottle of whiskey at one go. That type of excessive binge drinking at one instance, which then causes this. Steroids can also cause bone death. So sometimes it can be given by GPs in order to control certain things. Let's say, for example, exacerbation of asthma, or maybe even joint pain. I try not to prescribe it because taking too much of this can sometimes lead on to this. But sometimes also there's no choice for certain medical conditions. Let's say, for example, the use of it in cancer, chemotherapy, or rheumatoid arthritis, it can actually lead on to you have no choice but to take a steroid medication, and it's just that duration is dose dependent. The larger the amount, the higher the dose, the more likely this occurs, and also it's time dependent. The longer the duration of use of this medication tends to also cause this problem, and it doesn't actually cause risk to only one hip joint. It causes risk to two hip joints itself. Okay, so let's say, for example, a person who comes in to see me due to bone death from a hip joint with hip arthritis, the likelihood of the other side actually having the same problem is roughly 50%. It's just that it is actually maybe not so obvious yet. Okay. Yeah, to the patient, because they are not in pain in that area, but the other side is also affected. Okay. So I would say that steroids also tend to have a lot more other side effects than just bone death. Bone death is actually one of the more benign, less risky side effects. It can actually cause potentially other things which can be literally life-threatening. So excessive use of steroids is something which shouldn't be actually considered long-term unless there's really no choice. And normally, when you're on steroids for long term, the physician who is prescribing it to you will tell you some of the potential side effects. Okay, so sometimes the more worrying one is actually when steroids get shadily added into certain over-the-counter medications, let's say from TCM or even Thai medication, or even a jamu, or even herbal medication. The problem is that what happens is that the tendency is that we tend to see it actually being added into it and then being vouched for the cure-all. It is not regulated. We can't really, HSA has no way to check on every single medication for this itself. So the ultimate truth is that we cannot really vouch or don't vouch for the use of these style of therapies, because we aren't really certain whether actually there are any steroids inside or not. And it's not very easy to actually check for the presence of steroids after it's been mixed into the pill itself. So HHA does test, but it can't be testing everything. So the ultimate truth is that actually, in this case, it's a buyer beware type of situation. Okay, so once actually now that we know what are the various causes for hip arthritis, let's talk about how do we actually treat hip arthritis itself. So I think number one is where is actually the pain. The first thing is we sometimes want to make sure that it's not pain from somewhere else, which is causing the sensation of pain in the hip. So normally, typically, hip pain tends to be found in the front of the groin, the thigh, and the knee. Okay, in that type of pattern which I see over here. Some individuals who come to see me might actually come in initially due to just pure knee pain in itself. And when I actually examine them, their knee is totally fine, X-rays are fine, and then we start getting suspicious, or I start suspecting that it's actually from the hip. And when I do an X-ray of the hip, yeah, I can see a significant arthritis in the hip joint. So it's interesting that hip pain coming from the hip joint is actually not just pain in the hip, but also pain in the hip, the thigh, and the knee. Now, that type of concept, that pain, it doesn't actually stay, pain, problems in one particular area can cause pain in the distributed region, can also apply in the area of the spine, because pinching of the nerve of the spine itself can cause pain along a long track. But sometimes it can be just as simple as pain in the buttock, pain in the hip, and that actually is one of the common possibilities when patients come in with hip pain. Maybe actually it could be pain actually arising from the nerves from the back itself. So it's something which the physician would need to exclude. Oh yes, I think I got some slight errors over here. This was actually meant to be in front, okay, but in this case, right, it was actually swapped. Okay. So another way to actually reduce pain in the joint, especially with arthritis, is to lose weight. Losing weight here in this case, it will be difficult to run and jog, but maybe let's say like cycling with the seat as high as possible, so as not to destroy the knees in the process of doing cycling itself, so that you don't bend your hips too much. That will actually help to allow for a level of aerobic training and to lose weight without any force passing through the knee. Swimming is also always a good option, and if a person is unable to swim, then maybe even just walking around in the swimming pool is another way of actually helping to allow for use of calories without unnecessary stress passing through the hip or the knee itself. The hip joint actually receives times 2 force of body weight whenever you actually stand and walk on a single leg. Let's say like whenever you walk, one leg to the other leg itself, each time you actually put weight on one leg itself, it actually receives roughly about 2 times the force of weight. And that's really a combination of not only the body weight passing through, but also the need for your muscles to contract, to hold the position. And that contraction of the muscles itself causes additional stress passing through the hip joint. Okay. So ultimately enough, losing weight actually helps because it's actually a force multiplier. A 10 kg loss of body weight leads on to actually 20 kg less force passing through the hip. And that helps to reduce all that grating, grinding, inflammation type effects in the hip joint. The use of walking stick, of course, is a good idea. That helps to actually offload stress through the area. And these are some various examples. A walking frame, of course, is the most stable one. But I mean, most times it's very difficult to mobilize around. Sometimes this might be actually available, but this would be actually one which is very dependent on the individual itself. The good thing about this one is that actually there's a seat. So whenever the individual is tired, they can actually put a seat. Always remember there's a need for brakes, because without brakes, there's a chance actually of this wheeling off and causing a fracture. Walking stick is always a good idea. These are some of the various normal ones which we can see over the market itself. More often than not, always a good idea to actually have one which has a strap, if possible, because the strap helps you in case you accidentally drop the walking stick. You won't want to suddenly try to lurch forward to pick it up, and is that lurching forward which causes the individual to fall and cause a fracture. So this actually is one way of actually preventing that. And of course, for the occasional pain, there could be a discreet way of actually using a walking stick or hiding a walking stick, so as to use as and when there actually is a flare up. So just don't use an umbrella, okay? Because umbrella is one in which it's actually pretty thin. If you open up the umbrella, you realize, right, that the diameter of that umbrella, at least in terms of that long pole itself, it's actually much thinner, right, than the diameter of any walking stick. And that makes it actually not the best candidate, because once the umbrella breaks and you fall down, you will break, and that's the problem. Yeah. So I would normally advocate not to use the umbrella as far as possible. Daiso sells walking sticks. and those walking sticks are actually pretty good. Okay, so I know it's actually not a cost issue. It's to do with actually aesthetics, most probably. Yeah, but unfortunately, in this case, it's a trade-off. Okay, so how to hold the walking stick? Now, it's interesting. For a hip fracture, the idea actually is to hold the walking stick away from the affected leg, and it's actually a bit non-intuitive, but that actually helps to reduce pain more than actually holding the walking stick on the affected side. Okay. Physiotherapy is good because a lot of times, because of prolonged lack of use of the hip, it tends to actually contract. And when it gets contracted, there's a lot of stiffness in the hip. And it's the stiffness which then causes all the aches and pains due to excessive sprains occurring in the area. So physiotherapy helps to ensure that all that contracted parts are actually stretched out adequately enough in order to actually prevent all these sprains, aches and pains from sprains occurring. More importantly, also it helps to strengthen all those weak muscles which are not used for quite a while, and that helps to actually prevent falls and hip fractures from occurring. And at the same time, it helps to actually just move the joint to allow for all that natural joint oil which has been created inside the joint to actually move around and lubricate the entire area. Okay, painkillers are plenty. I can tell you, medications through the skin doesn't really go into the hip joint because the hip joint is pretty deep. It's very different from the knee. So all these medications are actually not useful when it comes to the hip joint itself. Now, and some people would then ask me, and the only alternative is oral medication. And oral medication is useful to help to relieve inflammation, but ultimately, also they are also side effects of oral medication too. So a lot of people tend to ask me about glucosamine, chondroitin, collagen, MSM, and all these other things. But does it help to actually add on new cartilage? Does it help to bring back the joint back to its original shape and position, and help to actually return back to a normal lining? Well, I can tell you, unfortunately, the reality is no. Okay. I think the best way I can actually explain it, and I've actually presented this roughly about 2 years ago, and I'm presenting again now, and I've started to develop new ways of actually explaining this. So the latest way, which I have, the best way of explaining this actually is the same idea as white hair, because I realize as we get older, we tend to get white hair, and there's really no perfect medication which actually can convert white hair growth back to black hair itself, or we can compensate. We can actually dye the hair black. We can actually trim our hair, but even then, as the hair grows, it's still white underneath. So the same idea here. We're actually taking glucosamine, chondroitin, MSM. They aren't exactly making the hair go back to its ability to grow again black. But so it's the same idea. It doesn't really allow the capping of new cartilage to occur. The pu, shall we say, the Chinese term of the cartilage back into the original place. But what it does is that all these tend to add additional lubrication to the area itself. So yes, it's useful. All these are useful to help to actually add lubrication so that actually that rusty door hinge or the rusty joint is actually moving easier than before. However, it doesn't mean that the rusty door hinge or the rusty joint is less rusty. It just means that it actually moves easier, and that helps to actually relieve pain. So all these tend to actually be a form of, in a way, painkiller, because they're actually there to lubricate, and when they lubricate, they help to reduce pain. Now, whether actually this gives long-term good effects, ultimately enough, the best way of saying it is that if it helps you, continue taking it. But if it doesn't help, after a 6-month period, my recommendation is to stop it because it's not really working anymore. Gel injections to the knee as possible, but gel injections to the hip is pretty deep. The hip joint itself, it's not easy to actually inject straight into the hip. Although there are actually services in hospitals which does that, we tend to see actually it not being done that frequently. And the reason why is because this joint is a pretty deep joint itself. It needs to be done under radiologic guidance. And the gel itself is exactly the same as taking any of the medications previously. Essentially, just literally adding a single oil to the joint, to the rustic door hinge. So what's left? In this case, for the elderly with arthritis, the recommendation then is actually to do a hip replacement surgery. Now, we don't do these things lightly. Normally, we will only consider an offer if quality of life is affected. So when is quality of life affected? That's when it's actually at the very number one, pain, doing most activities, the cone of function, that means the ability of an individual of doing things itself is getting progressively restricted. So let's say, for example, cannot go to the market, cannot go to the supermarket, cannot commute to work, got a difficulty in being able to go to toilet and back, got progressive difficulty of in being able to actually even put on the shoe or wear socks or being able to sit cross-legged. Pain, especially at night, stopping the individual to sleep. Ultimately enough, quality of life is relative to the individual, because everybody sees life differently, quality of life differently. It's really down to the individual itself. But as more and more of these activities are curtailed or restricted due to arthritis, more often than not, quality of life quality of will start to actually get more and more affected. And that's when we start thinking along the lines of, is there any possibility of other than non-surgery, other than all the other methods we discussed before, there's a way to actually relieve pain by surgery itself. And this is the way, it's hip replacement surgery. Interestingly, based on the statistics, the hip replacement surgery is the second most significant way of improvement of quality of life compared to cataract surgery. Because clearly, with cataract surgery, a person's vision is improved quite dramatically. So it's night and day type of effect. While hip arthritis surgery itself, that means using a total hip to actually do surgery, is also a bit of a night and day event where significant pain in the hip is actually significantly reduced, and to such effect that actually most patients, right, after a hip replacement surgery, they're able to stand and walk immediately within a day or two. And the reason why is because, right, they felt that actually their pain from the surgery itself is much less than actually the pain from the hip arthritis. And so they feel that actually the pain is much less dramatically immediately after surgery. So, okay, let's talk about surgery itself. How do we do about it? So in this case, what we have to do is, the area of concern is the head. We will actually do a controlled cut. Essentially recreating a fracture, okay, in this particular part of the bone. Remove the affected bit, and then after that, then we would put in artificial head together with a stem, and which is held down by cement, or sometimes held down just by a good fit. In this case, just putting a head is not good enough. Normally, this part here also needs to be changed. So we will actually change it with another cup. So it's not only just the head which is changed, but also the cup is changed too. So this is actually some examples of what you can see over here. Most times they actually tend to be quite modular. You can see a cup with a plastic liner inside, or maybe even ceramic. Okay, because ceramic tends to last longer, but they also are much more expensive. And also at the same time, there's a chance of it actually breaking because of it being ceramic. Okay. But this is meant for those who are below 50 years of age. Those who are above 50, we tend to give the plastic liner because we don't worry about long-term longevity of implants then. And then after that, then we have a head. So the head, this is the stem. Head is inserted to here, and this little head articulates, that means moves with the surface of this plastic, which is embedded within this cup. This cup doesn't move at all. This cup is actually firmly implanted into the bone over here. So if I were to say this part here is part of the waist bone, the pelvis. This part here is part of the thigh bone, the femur. So the area of movement is here, between this and this. Okay? So it's what you see over here, roughly. So this example, this patient over time started to actually have progressive arthritis with flattening of the head. In this case, we actually changed the cup. We changed this cup with this metal liner. There's plastic inside, and then there's a big metal head with a stem. Now you see there's this screw over here. This screw is there to actually just hold the cup in position until the bone starts to grow into the cup. Once the bone goes in the cup, the screw actually is actually doesn't serve any further function anymore. But the screw does serve a very useful function at the very beginning of immediately after surgery itself, because that gives us confidence to allow the individual to stand and walk as soon as possible without fear of the cup moving. So unfortunately for this individual, the other side also was involved. This patient actually has a bone depth of the hip. And this bone depth itself, normally, when the person presents to me with arthritis to one side, more than 50%, close to 75% of the individuals tend to also have bone depth on the other side with time, over a 2 or 3 year period of time. Can it be prevented? Not really, because the occurrence, the event which caused the bone depth has already occurred. Okay. So in this case, the right side started to actually, the right side, which is this side, yeah, the left side on your screen, started to actually cause progressive issues, and eventually this individual had to undergo both hip replacements. The person is actually pain-free and walking quite nicely. Bear in mind, this individual also has spine surgery in the past, as you can see on top. Okay, so what are the risks of surgery? This is going to be actually my last slide for this presentation. Generally for most surgeries, there's always going to be a need for anesthesia. So there's always that risk of heart attack, lung infection, and stroke. This actually tends to be within the 1 or 2% for the healthy individual. Of course, right, for those who actually tend to have medical conditions, the risk will be higher. Age also tends to increase that risk of anesthesia. So above 85 years of age, this 1 or 2% doesn't actually become that predictable. It becomes a bit higher. It's not incredibly high too nowadays with modern anesthesia, but at the same time, it's something which we cannot say that it's not below that 2% range itself. Okay. Infection is another potential risk, because any sort of surgery requires us to breach the skin. We do these surgeries pretty cleanly, and we always give antibiotics to prevent infections, but never say never. There's always that statistical chance of infections occurring, and normally most times the code which we give is 0.5 to 1% or less. Okay. In my case, I've only actually my infection is roughly in that ballpark figure itself, and it's really statistical, because more often than not, most times this infection risk is actually due to other causes, potentially like urine infections or other forms of infections occurring, which then causes seeding of the area with bacteria. The risk of cut nerves leading on to the foot being unable to be raised up is a possibility, because there's actually a large nerve which runs at the back of the hip replacement, or the back of the hip itself. This can be avoided by doing surgery carefully. I tend to actually give more time for hip replacements to ensure that this doesn't occur. Fractures can also occur during the process of actually cutting and removing the head, or sometimes putting the stem into the femur itself, this metal prosthesis into the femur. So this one is also dependent on how osteoporotic the individual is. Ultimately enough, there are many ways and means to actually mitigate this. But worst come worst, if this occurs, normally most times it's actually just an exchange of implant and putting a much longer implant in to actually bridge across that fracture site, and that more often than not allows for mobility sooner than later. Blood clots in the legs can also occur due to after surgery being lying down in bed, and that is something which we discussed previously during the hip fracture component. One important thing which is more peculiar to hip fractures is this concept of there being a change in limb length after surgery itself and the risk of dislocation. I'll discuss about dislocation first. So depending on how the surgery is done, whether it's in terms of approach, there's always a chance that the head itself, that means the circular ball bearing here, can actually pop out of the cup. Now, this one tends to only occur in certain individuals and also in certain positions. So normally after any form of this style of surgeries, we normally advise what we call general hip precautions the patient to actually avoid specific activities. One of them is deep squats. That means the bending the knee fully until actually they're literally like sitting close to sitting down on the floor, that type of idea. Not getting into low chairs, okay, or low sofas, and not crossing the legs, because all these activities tend to increase the risk of dislocations from occurring. Now, limb length discrepancies or limb length differences occur because when we actually implant this stem, we can put them a bit deeper, a bit shallower, and that can actually cause there to be actually a slight difference in length between one leg to the other leg. So normally, statistically, there's actually a difference of roughly about even up to 1 cm for up to 20% of individuals when after surgery itself. Normally, 1 cm is quite well tolerated. It just requires, and with very mild need to change in terms of gait and maybe even shoe wear. However, sometimes there could be instances where after we implant all these implants, that actually we realize that there is actually quite a lot of loose. The surrounding tissue is so loose that this head tends to easily dislocate out anyway. So sometimes, in order to actually prevent the dislocation event, we have to deliberately put it a bit longer. And in those individuals, we will counsel them well that to expect that actually that leg will actually be longer at times. Sometimes we can't predict exactly who these individuals can be. So at times, right, almost everybody has to accept the fact that if in order to prevent that risk of dislocation, we might have to deliberately keep that leg long. Okay, so that can be sometimes up to even 1 cm in 20% of individuals. Okay. But it's actually pretty tolerated quite well. Why? Because if we were to actually measure our limb lengths on both sides, left and right, we will realize actually there's roughly about a difference of 0.5 to even sometimes even up to 1 cm in close to about 15 to 20% of the population. So it doesn't, and these individuals are totally don't have any symptoms. They don't actually even notice that there's actually a difference in their limb length itself. And it's just something which actually is just picked up just by sheer measurement after the fact. Yeah. So I think that's it actually for my talk. I will just give so in summary, what I've gone through is what is a normal hip joint, the concept of hip fractures, why, how it occurs, what are the treatment options of hip fractures, and also how to prevent it briefly, the ideas of hip arthritis and the idea of bone death itself, and what are the specific things which can cause it. So these are things to avoid. Example like the excessive use of steroids, maybe being very, very careful of what sort of TCM, JAMU, or Thai medication one is taking, the use of alcohol. Talking about steroids, there's quite a number of people who actually have been self-treating their gout with use of steroids. Previously, before COVID, they will either go to a few centers, like Godamara Complex, to buy the Thai version of this steroid, or go to over the causeway to buy steroid, and then they use steroid as a way to actually control their gout. So for these individuals with gout, it is strongly advised to actually avoid the use of self-medication of steroids as a way to treat gout, because these would then lead on to actually this bone death with eventual hip arthritis. And the last thing which I discussed about is hip fracture surgery. Okay, I think that's it for my talk. Maybe what I'll do now is go through a few questions and see whether I can go through as many as I can. Give me a moment. Okay, let me stop my screen share. Oh, it's lagging a bit. Okay, can. Okay, just give me a moment. Let me go through the Q&As itself. Okay. Okay, okay, first question. I think I'll just go through in order chronologically. I think it's easier that way. Okay, for elderly age 82 and above for surgery after prolonged pain for the past few months, the reality is that it depends on a few things itself. So the thinking process, which I will always recommend for everybody, is what we are trying to balance here is the risk of surgery and the risk of anesthesia versus like quality of life. So for anybody, whether it's age 82 or even younger, it's really this combination of things. So ultimately enough, if let's say like the risk involved is too high and it overwhelms the benefits, then maybe surgery is not a good idea. But let's say like if the risk is actually pretty low and the benefits are there, then it's really down to judgment. It's a value judgment of the individual, or whether they actually wish to embark upon this. Okay? Because it's not only just to do with suffering from the pain after surgery, but it's also to do with the fact that you are actually trading off a short-term suffering for relief of long-term suffering, shall we say it that way? And everybody has a different value judgment. So there are certain things which are absolute. Let's say for example, the risk of a heart attack for a person with previous history of heart attack can be pretty high, sometimes even up to 30%. So if that's the case, then it's actually Russian roulette. It's literally like a 30% chance of a heart attack during surgery itself. More often than not, it's not to say that we would not actually recommend surgery. We will say that I would say that actually surgery is a possibility. However, think very, very, very deeply and think very, very hard about getting yourself exposed or getting a person exposed to 30% risk of a heart attack before surgery, because of surgery itself, because of the effect of receiving anesthesia itself. In this case, I would say it really depends on after 65 years of age. I will tell you in reality, it's less and less to do with age right now, and it's to do with actually all the medical conditions accrued over time. A person who is actually 60 years old with multiple medical problems, diabetes, heart attack, and stroke, would actually be physiologically much older than somebody who is actually 90 years of age, who actually has no medical problems at all. Because a person who is 90 years of age with no medical problems tend to actually be relatively fit, pretty fit, for them to actually reach that age without medical problems too. So then for them to actually receive anesthesia, the likelihood of actually risk are actually almost equal or less than somebody who's actually younger with medical problems too. So I would say that it's really, really down to both, not only just due to age, but also to do with previous medical problems. Okay. Is there a super glue option? Okay, yeah, I hope that answers your question. Okay. Yeah. If that answers your question, I think that's it. Okay. Is there a super glue option on top of screws? I would say that super glue options are actually one which is quite interesting. That concept itself. No, we don't actually. There's no way in which you can actually glue fractures together with super glue, but we do use cement as a way to actually inject cement into bone to harden the bone up, or to make the bone be more, shall we say, harder than what it is before. So that is when we actually lay down the screws or put screws in, it holds everything in place. Okay, I hope that answers your question. Would you need to remove the screw and plate? Ultimately, no, because when you actually remove the screw and plate, what is actually will happen is that holes will be left behind, and these holes actually destabilize the would actually be a risk to fractures in that case. Some people still insist on removal, which is fine, but I normally would not recommend because most times, right, here we are, going for surgery at the elderly age to allow for individual to actually go back to walk and move around and have less pain and be easiness. That's understandable. The benefits outweigh the risk. But coming in again to remove the screws and plates, where actually the person is able to already is pain free, doesn't require any form of nursing, and is actually functionally mobile. Now that's when actually it becomes a bit more iffy because the benefits in this case get outweighed by the risk. Yeah. So each time, right, when we actually think of surgery, it's always a balancing act between these two things. Yeah. And in this case, right, it's a bit different because the aim of surgery is to actually allow for mobility. Now, removal of screws and plates, the aim is just essentially just to take it out. But the screws and plates don't actually cause any long-term problems to the body. If it will cause any long-term problems, it's roughly a couple of 100 years time. So it shouldn't be an issue at that age group itself. Ultimately enough, the only time when we consider removal of screws and plates is if something has a complication has occurred. For example, let's say like the plate has broken or the screw has actually cut out and has gone into the hip joint or one of these things. Normally, all these complications occur. Why? Because of the fact that number one, the bone just doesn't want to heal for some reason, or number two, the bones are just way too soft. Hope that answers your question. What material is used for screws and plates? It is a combination of materials. Yes, titanium is one of them. More often than not, also it can be also stainless steel. Stainless steel surprisingly is one which is very, very biocompatible also, and it's actually one which can last for the test of time, at least for a few hundred years without any issues in the body. Normally, titanium is one which is used for the rods, the long rods which we see, while plates and the screws are actually made of stainless steel. But no matter what, the general principle is that if titanium is used for one thing, more often than not, everything is titanium. If stainless steel is used for one particular part of that construct, normally everything is stainless steel. We just can't mix the two metals together as best as possible to prevent this concept of galvanic corrosion. Okay, with regards to advanced aging process, is there still a way to preserve bone density and strength? Yes. Let me just read the rest of the question. If there is, what would that be? Is getting sunlight exposure is better to consuming vitamin D? Okay, the reality is that it's actually many processes. I think maybe what we talk about is the aging process of the bone itself. So we need to think of bone as muscle. When you do bodybuilding, the muscles get bigger and thicker. Same idea here. Bone also is the same concept here too, where actually the more you use your bones, the less likely actually the density of bone reduces. So this is a use-related thing, where actually doing some very, very gentle weight training helps. It's not to do with aerobics, it's to do with weight, stress passing through the bone itself. So a bit of gentle weight training helps. Must be very careful when you do that because we don't really want to actually cause arthritis, wear and tear of the joints. So some will actually even advocate as simple as getting into the middle of a door frame. That's what they actually had in terms of one study, and literally pushing out the door frame itself if the door is that low, so that actually there's enough stress passing through the body to actually cause a gentle increase in bone density. A lot of times also is to do with the ideas of the use of vitamin D and calcium. Calcium supplementation, the reality is that it's only maybe more for the postmenopausal lady, maybe 5 or 6 years later down the line, maybe calcium supplementation might make sense. Normally about 1 gram, that means 2 tablets, or rough as a ballpark figure. The reason why we actually tend to say that instead of say drinking milk is because as we get older, especially in Asian populations, we tend to actually be more progressively lactose intolerant, and the equivalence of 2 tablets of, it means 1,000 milligrams of calcium is actually almost 5 to 6 full glasses of milk, and nobody's able to consume that level because it tends to lead down to quite severe diarrhea and bowel upset. So most times, right, that's the problem. Now, the important thing to always think about is that calcium absorption is related to also vitamin D. So you need to actually have vitamin D or adequate levels of vitamin D in order for the small bowel, the small intestines, to absorb all that calcium. So calcium itself, right, vitamin D is quite important. And one way to get vitamin D is, of course, through the tablet supplementation. Another way is also to do sunlight exposure. And most people don't like to actually get sunlight because of UV radiation, or because of, but it's the UV radiation which actually causes this development of vitamin D in the skin itself. So my advice is maybe morning sun or evening sun, where it's nice and orange. That's the time to actually get exposed to sun.